We're good. We're recording.
Okay. All right. So Beth Darnall is a professor at Stanford School of Medicine. She is in the Department of Anesthesiology, Perioperative, and Pain Medicine, where she directs the Stanford Pain Relief Innovations Lab. Her pain treatment research is funded by the National Institutes of Health and PCORI, or Patient-Centered Outcomes Research Institute. She doesn't say it here in her bio, but she is an extremely successful, well-funded researcher, and who I came to know a little bit while I was at Stanford, and was really excited about her research. Her work involves brief, digital, scalable, and home-based pain relief interventions. And she has on three separate occasions briefed the U.S. Congress and the FDA on patient-centered pain care, opioid stewardship, and voluntary prescription opioid tapering. She is a scientific member of the NIH Interagency Pain Research Coordinating Committee and served as a scientific member of the CDC Opioid Work Group. She is also chief science advisor for Applied VR. And I don't know if you're going to talk at all about that.
No.
Beth, no, sorry.
No.
Just a very interesting virtual reality for pain relief, right? Okay.
Yeah.
It's very interesting. Serves on the board of directors of the American Academy of Pain Medicine, and serves on the medical advisory board of the Facial Pain Association. She has delivered keynote addresses all over the world, including, we're all very jealous here, Australia, New Zealand, the Netherlands, the US, and the UK. And her work has been featured in places such as Scientific American, The Guardian, NPR Radio, BBC Radio, The Wall Street Journal, The New York Times, and Nature. She has authored 5 books for patients and clinicians. And in fact, Beth and I, because I worked with older adults at Stanford and had gotten to know you, one of the books, in fact, I used to have it right here on my shelf, but it's called, I think, Less Pain, Fewer Pills. Is that correct?
Yeah, that's one of them. Yeah.
Yeah. And so that's one you could recommend to your patients, really about this kind of brief, and very patient friendly, user friendly ways to deal with pain with less pills. So she's authored 5 books for patients and clinicians. And in 2018, she even spoke on the psychology of pain relief at the World Economic Forum in Davos. All right, take it away.
Well, thank you so much for that. Very warm welcome, Laura. And I'm really delighted to speak with all of you today and just share some of the work that me and my group have done. My training is that I'm a clinical psychologist, so kind of part of your world, and but have a courtesy appointment in the Department of Psychiatry and Behavioral Sciences at Stanford. So without further ado, I just want to dive right into the content that really matters. And where my work focuses is on broad integration of evidence-based behavioral treatments for pain. So really across the continuum of care, and different settings, different patient populations, et cetera. So I'm sure you see this in your patient population as well, because there's a large comorbidity between mental health conditions and pain. Pain is the #1 reason people seek medical care, and it is very prevalent to the point that up to 1 in 3 Americans are living with ongoing pain of some type. And of course, that is a tremendous economic consequence, but most importantly, confers suffering for individuals and their families. So with this big pain crisis that has really been afoot for several decades, we've seen multiple national institutes and agencies that have called for a different approach to treating pain. The calls are for a whole person approach that really addresses the needs of the entire person. And you'll see here, just on this slide, this is just a brief listing of some of these institutes and agencies that have called for this whole person approach. But while we have good agreement about what needs to happen at a national level, we really have failed to implement actionable solutions. And that's where my work has focused very keenly. So it remains today that if you have pain or a member of your family experiences pain and they go seek medical care, that it will be really worked up primarily as a biomedical phenomenon. And we need good medical approaches. Don't get me wrong, that's vitally important. But if we're only focusing on the biomedical perspective in isolation, it turns out that that is a very big disservice to our patients, that then we're failing to address the full definition of pain. So the actual definition of pain is that it's both a noxious sensory and emotional experience. So we see that the psychology is actually baked into the definition of pain, but I think we could probably all agree that that truism is lacking when it comes to treating pain. Now, all pain is processed in the central nervous system, the brain and the spinal cord, regardless of where a person feels pain in their body and regardless of the etiology of their pain. So across various medical diagnoses and comorbidities, still pain is processed in the central nervous system. And so then it begins we can really understand why there is such an overlap between mental health conditions, between psychological distress, and the experience of pain, because there is this overlap in the central nervous system insofar as how pain is processed and experienced. Now, I describe pain as our harm alarm. It is designed to get our attention, and it does so very effectively. It gets our attention, it alerts us that there is danger in the environment, that there's a threat to our being and potentially to our survival. So it's really served that very useful purpose in terms of motivating us to escape pain, to confer protection, and therefore safety and our survival. So pain is very useful. If I place my hand on a hot stove, I'm not even going to have to think about what needs to happen. My response is going to be automatic, absolutely automatic. And so this is incredibly important that pain registers this way as the harm alarm, because it helps us survive. But still, we recognize that once people have acquired medical conditions, medical comorbidities, diagnoses like rheumatoid arthritis or fibromyalgia, or maybe a person has had multiple spine surgeries and they have ongoing pain as a consequence of these medical realities. We see that in those cases, once pain has become chronic, that harm alarm ringing is no longer a useful signal. And in fact, it becomes problematic at that point, because it is ringing and it is urging us to escape the pain, and we can't just run away from migraines or from these diagnoses. We can't escape the pain that's being generated from inside of us. And so, of course, pain is distressing. Of course, we see comorbidities with depression, with anxiety disorders, and with the experience of pain. And so it's common when we're working with people who are living with ongoing pain that they may have a lot of difficulty in how they respond to the pain. Feelings of helplessness, hopelessness, despair, feeling that there's nothing I can do about my pain, and I know it's only going to get worse. So this is a common experience for people to have, and it's important that we address it. And while we're all born with the motivation to escape pain, we're not born with the understanding of how to modulate pain and the distress that it naturally causes us. And this is really the realm of pain psychology or behavioral pain medicine. Sometimes people might call it pain self-management. Some of these terms are a little interchangeable, but it's the idea of helping people learn how they can best help themselves manage their pain. Now, the best studied intervention, behavioral intervention for chronic pain is cognitive behavioral therapy for chronic pain. It's really specific to pain. So this is to be distinguished from CBT for anxiety or for depression. It's tailored. The content is very specific to people who have chronic pain, and all of the topics and the skills, while they may be similar to other types of CBT, they're really tailored and contextualized within the experience of chronic pain. So people will learn about pain in the brain, the relationship between mood and pain, sleep and pain, etc. As with other types of CBT, there's goal setting, problem solving, action plans, and then there's core skills that people learn around affecting the relaxation response, cognitive restructuring, some mindfulness principles. And generally, CBT is delivered over the course of 8 sessions. So it's about 16 hours of total treatment time. Sometimes it's up to 20 or 22 hours of treatment time. So this is a multi-session treatment that does require a fair degree of investment in the people who would receive it. But it's the best studied treatment. Now, notice I didn't say it's the treatment with the best evidence, because there are other treatments that have relative equivalence, but CBT is really the best studied. We have the largest body of evidence to support it. So at the end of treatment, we could hope for this type of best case scenario with our patients. This woman saying, okay, maybe my pain is a 7 today, and there are several things that I can do right now to soothe myself and help myself feel better. So it's a shift in perspective, it's a shift in action, and this is what helps people live better within the context of pain. And it also has primary analgesic effects, which I will explain to you. So as people acquire and use these skills, we can see, I'm going to show you a video next, and it's a fMRI video that shows what happens in the brain and what changes in the brain from the context of a person focusing on their pain and how awful it is when they're feeling helpless about it. And when they are applying some of these pain relief skills that calm the nervous system, that move them into right and adaptive action, when they're focusing on that, and we can see this juxtaposition of what happens. So I'll play the video now. So when people are having these unhelpful thoughts about pain, we can see real-time amplification of pain in the nervous system. And when skills are being applied, we see that real-time dampening of pain processing in those regions of the brain associated with pain. Now, you know, that's interesting, but of course, people don't live in scanners, and we don't just want to help our patients feel better for a moment or two. We want them to gain lasting relief. And so how do we help them achieve lasting relief? This is really achieved with regular skills use, where they're learning how to dampen pain processing, reduce physiologic hyperarousal, where they're extinguishing some of those unhelpful responses to pain, and they're entraining positive neural patterns that confer relief. What the data shows is that when people engage in these skills regularly over time, that they alter both the functioning of the brain as well as the very structure of the brain itself. So this was shown in this study here that you see, David Seminowitz and Magdalena Naylor did a really cool study where they took people with chronic pain and they scanned their brains at baseline. And then everyone in this study underwent 11 weeks of CBT for chronic pain. And then they scanned their brains again at the end of treatment 11 weeks later. And what the researchers found is that pre-treatment, people with chronic pain evidenced volumetric deficits in key regions of the brain associated with pain control. But 11 weeks of learning information, practicing and applying skills at post-treatment, they scanned their brains again, and those scans demonstrated substantial volumetric increases in those same regions of the brain associated with pain control. And those brain changes, those structural brain changes, correlated with patients' report of reduced pain at post-treatment. And the most fascinating part of this study to me was that these structural brain changes were entirely mediated by people gaining better control over the cognitive and emotional responses that they had towards pain. So if they were able to decrease this construct called pain catastrophizing, and if they were better able to self-regulate cognition and emotion within the context of pain, that is what predicted these structural brain changes 11 weeks post-treatment. So this is kind of cool for a couple of reasons. One, it demonstrates how our behavioral pain treatments can confer long-lasting relief. And it also teaches us that these changes happen fairly rapidly within a 3-month time frame. Now, it's common when you're working with people with pain, they might say, oh yeah, you know, I tried that once and it helped for a few minutes, but my pain returned. So we have to help orient our patients to the concept that, you know, it's not like taking a pill where you take one, let's say you take one antibiotic and it's cured the infection. It doesn't work that way. We are literally entraining neural patterns and the results unfold over time. But they unfold much more quickly than people might think. So we usually communicate to patients, you know, as they're learning information, stay with it for 2 to 3 months, because that's your best chances of gaining the long-lasting relief. So the evidence for pain CBT has been pretty powerful, to the point that in 2018, this Lancet expert review and consensus panel put forward that, like, we should be connecting patients to CBT and pain education as first-line treatments for chronic pain. But, you know, we almost laughed because nobody gets this as a first-line treatment. And we studied some of the reasons why this is not offered as a first-line treatment. And none of you are going to be surprised about these reasons. These are probably some of the same reasons that stand as barriers to receiving any of the multi-session treatments that you may offer in your clinics. It's insurance, it's time, it's co-pays, it's just feasibility within the context of a person's life. So with
Dr.
this
Darnall?
yes, sorry.
I think we're getting there's an artifact on your screen. You may have like a comment or chat bar open. We're seeing like a black bar across your screen. So if you could close any questions or chat bars that may be open.
Oh, interesting.
You probably don't see it, but
did that do it?
Well, one appeared and disappeared. I'm not sure where this is. There may be another one like in the chat or maybe.
Oh, I don't unfortunately I don't see anything in my chat box, so I don't know how to eliminate it. Does it block the view of my slides?
It's blocking part of the, actually, if you could stop sharing and resharing, that might fix it.
Let me try that. Okay. Let me try resharing. And then let me.
It's still there.
Is it still there?
Yeah, I don't know what's causing this. I could share your slides if that would help, or
My only concern about that is I'm gonna play a video and I don't
Okay.
know if it will work well with that. Yes, what do you think? Is it good enough where people can see it, or should we just forego the video and you do the slides?
When is the video? How soon?
Oh, it is probably, it's towards the end. So I would say maybe in like 15 minutes or so.
Andy, do you have the slides?
I do, yes.
Oh, wait, it's
I-
gone.
Oh, it's gone. It's gone. I don't.
It's gone.
No, now it's back. Oh, this is so perplexing. I don't know what's going on here.
It could be the cursor. Move the cursor away.
We have a gremlin.
How's that? My cursor is gone.
No, we're still seeing the bar.
We had this problem before.
Yes, I don't know why. No, it's gone. It's gone. It's good.
Okay, so how about this? Maybe I'll just keep going and then you stop me if it starts going crazy again.
Sounds good. Thank you.
Okay, so with this great need, with this vast population, did it come back by any chance?
No, it just came back. It just came back.
I
Well,
said, you know
someone-
what?
But someone put actually, no one put things in the chat. Oh, there's something there's some instructions in the chat. Maybe if let's just close. No one put messages in the chat until the end, because I think messages in the chat are creating the black bar up here.
Is that right? Okay. Would you
It
like
seems
me to
be
continue?
correlated with that? Yeah, just continue and hold
Okay.
questions, including chat, to the very end.
Okay, terrific. So with this great need, I was describing this massive need for behavioral pain treatment, these calls for integration of behavioral treatments into pain care pathways broadly, but also the recognition that nobody's really able to access these treatments that are shown to work. Born out of this need for accessible options, I created Empowered Relief as a one-session intervention that rapidly equips individuals with effective pain relief skills. So I was working in pain clinics and evaluating patients and developing these treatment plans that theoretically they would go and implement in their communities or elsewhere. And what I was finding was no one was able to actually implement my treatment plans because there weren't skilled providers that were available to deliver these types of effective behavioral treatments. So that was the genesis of Empowered Relief, where I essentially took key information from several different types of treatments, from pain neuroscience education, from pain CBT, mindfulness principles, and synthesized it into a compressed one-session intervention, because I knew that while very few people could come back for multiple sessions, most people could receive a one-time 2-hour intervention. So that was the, there we go. So that was the genesis of Empowered Relief. So it's 2 hours in duration. It can be received in person or online, and large group sizes are possible. So with interventions like pain CBT or even other types of CBT, you usually have up to 12 or 15 people at a time. With our Empowered Relief classes, we have had up to 85 people in a single class, and family members are welcome to attend too. The reason for this is that it's not therapy, it is a interactive didactic intervention. So over the course of this 2-hour intervention, people participate in experiential exercises. They learn 3 core pain management skills. They complete a personalized plan for Empowered Relief, and they download a binaural app that they can use on a daily basis and integrate that into their Empowered Relief plan. And we have published data from 4 randomized controlled trials. So I'm briefly going to present to you the evidence for this intervention. The first study published in JAMA Network Open 2 years ago, almost exactly. This is an NIH funded study. We conducted it and people with chronic low back pain as the enrollment criterion. And we randomized them to one of 3 treatment groups. Either they received 2 hours of general back pain education, health education that did not involve any skills per se, or they were randomized to empowered relief, which of course is the skills-based intervention, or they were randomized to 8-session CBT for chronic pain. So our primary hypothesis was that 1 session empowered relief would be non-inferior to 8-session CBT for chronic pain. So this was a pretty high bar, hypothesizing that 2 hours would be equivalent to 16 hours of treatment. And, so it was it was a risky study for me to do, because the entire field was really focused on this multi-session treatment, which is shown to be efficacious. But we were really pleasantly surprised that our hypothesis was validated. Essentially, we found that empowered relief was non-inferior to 8-session CBT for all of these outcomes you see listed on the left-hand side of the slide, for reducing pain intensity, pain interference, pain catastrophizing, self-efficacy, improving pain self-efficacy, reducing pain bothersomeness, sleep disturbance, depression, anxiety, and fatigue. So we really came to understand that this 1-session intervention wasn't just targeting pain-related distress, it was really having multi-dimensional benefits, suggesting that it's just a primary pain treatment overall. It's important for me to mention that our primary outcome was 3 months post-treatment. So we're seeing at least those short-term, the non-inferior results in the short term. And while we haven't yet published our 6-month outcomes data, our manuscript is in review right now, and we show that this non-inferiority holds 6 months post-treatment. So in 2019, Health and Human Services had cited empowered relief as being a very promising, scalable intervention that might address the needs of a population. But this was our first evidence that it was actually effective. And we next wanted to know, well, what happens if you receive this one-time pain relief skills intervention online? And we conducted this study during COVID based on its great need at the time. So we enrolled 105 people from the pain clinic and randomized them to either receive online empowered relief or just usual care in the pain clinic. No in-person visits. And this was people with all different types of chronic pain, not just back pain. And we followed them 3 months post-treatment. And we found a similar pattern of results where we were observing multi-dimensional benefits for empowered relief that were in the moderate to large effect sizes for reducing pain catastrophizing, anxiety, pain intensity, pain bothersomeness, anger, and sleep disturbance. So that was a really nice outcome to have too, because most people are delivering empowered relief online these days. So for the past several years, we've been certifying clinicians in the United States and around the world to deliver empowered relief, to integrate it into their pain care pathways or their healthcare pathways. So we've certified 900 clinicians of varying disciplines. Some of them are physicians, some of them are social workers, mental health therapists, you name it. As long as somebody is a licensed clinician, they can become certified in empowered relief. We're delivering the intervention in 25 countries. It's available in 7 languages. It's been received by more than 10,000 people. These are just some of the organizations that have embedded empowered relief into the care pathways. one of the most exciting things for me is that people have adopted empowered relief as standard care, meaning that it's recommended that everyone receive it. So it really flips the script on the way that we have historically offered behavioral interventions, where we will often screen for people on a certain factor, like, oh, we're going to screen for distress or depression or anxiety, and we identify the people who need it the most and then recommend they get it. But instead, what we're doing now by integrating it as standard care is we're just recognizing that everybody can benefit by having enhanced understanding and skills to better self-regulate, and that across a variety of outcomes, we can help people improve. So we're shifting a perspective away from treating problems to optimizing healthcare and pain care for people. So if you go to Cleveland Clinic for spine surgery, you're going to get empowered relief because that's part of spine care surgery. And the same is true for many of these primary care clinics as well as pain clinics. So we are now studying empowered relief in a large pragmatic clinical trial. This is a national study, 6 study sites. We're studying it in 1,200 adults with mixed etiology chronic pain. It's called the Progress Study, and it's a partnership with Humana. So we're really getting a national sample of people. And this is going to allow us to test the comparative effectiveness of online 1-session empowered relief compared to 8-session CBT. We don't put forward that empowered relief should replace 8-session CBT. We just recognize that very few people receive 8-session CBT. So can we expand access and get people more rapid access, and also identify for whom is which treatment best? One of the nice things about this study is that we're going to have a really richly diverse sample. So the prior studies that I just presented conducted in the Bay Area. So we have a largely white patient population. And with this national study, we're really able to enrich for various factors to ensure that our sample is representative, reflective of the larger US population, and we'll be able to identify subgroups for whom the intervention may work better. So that's in progress to collect that evidence that speaks to these subgroups and diversity. This just shows you if people are interested in the Progress Study, they go to our website and they can click on where they receive their pain care or their health care and then join the study. So this, while this study is national, patients do have to flow through one of our study sites. And these are just some of the investigators and topics that are currently under study in terms of empowered relief. It's being studied in people taking prescription opioids. Dr. Sturgeon is looking to see if it can help reduce use of medications for migraine. Holly Watson is studying a nurse-delivered empowered relief in a national sample of patients. And we're studying it in opioid use disorder as well as in primary care in Canada. So these are all nationally funded studies. And this study, I actually need to change this slide because this study opened yesterday, so August of 2023, funded by National Institutes on Drug Abuse. We've created a digital version of empowered relief that is tailored to people with opioid misuse or OUD. So they need to have be taking daily prescription opioids, have chronic pain, and have some misuse behavior. And if they do, they can get into our study. It's fully online. And they have access to empowered relief. Some get it sooner, some get it a little bit later, but it's free treatment. It's all online. People can receive up to $170 for completing our study surveys. So I am shamelessly throwing out there for any of you who work with people with opioid misuse or OUD, and if you're looking for a way to connect them to behavioral treatment, shoot me an email and I can send you more information about the mobile relief study. It's national, so we can enroll people from anywhere in the United States. We have adapted empowered relief to teens, to youth with chronic pain, and that is currently under study at Stanford, led by Dr. Laura Simons and Dr. Lauren Harrison. And in the last few minutes, I just want to tell you how we have translated empowered relief into the surgical setting. And so there's a great need for behavioral interventions to better manage post-surgical pain. As you're well aware, pharmacology is really how post-surgical pain is treated. And so I adapted empowered relief. I tailored it to the surgical setting, made it digital so that people could receive it on a computer, iPad, or a phone, and to make it easier for them to access the intervention either before or after surgery. And this early version of empowered relief was called My Surgical Success. And it was, we studied it first in women undergoing breast cancer surgery at Stanford Hospital, and we randomized them to either receive digital health education, or to receive My Surgical Success, which is empowered relief, an early version of that. And then we followed them after surgery to see if it would make a difference in their pain and opioid use. And what we found was, this is a sample of 68 women, 36 in My Surgical Success and 32 in the digital health group. We were studying this 14-day window after breast cancer surgery when women are likely to be taking prescription opioids. And what we found was that the women who received My Surgical Success or empowered relief, they required about a week less opioids after surgery than the women in the control group. So because we were only looking at that 14-day window, it was a significant effect. And we were pretty excited about that because it suggested that even this automated version of empowered relief could have clinically meaningful benefits. So we next studied in this version of empowered relief in patients undergoing orthopedic trauma surgery at Stanford Hospital. And this was a study led by Mesa Ziadny and Dr. Michael Gardner, who's the chief of orthopedic trauma surgery at Stanford. And we enrolled people in the hospital post-op days 1, 2, or 3. So they've already had their surgery, they're recovering in the hospital. We go into their room, we enroll them, we give them an iPad, and they receive their assigned treatment, either the digital control or My Surgical Success, the version of empowered relief. And what we found was that people who received My Surgical Success reported less pain proximal to their surgery and all the way to 3 months out. And this was an important finding. You can see on the line graphs here, the natural history of surgical recovery is that pain is decreasing over time. So you see that with the control group too, but we see a meaningful benefit from people receiving this 80-minute intervention on an iPad. It's low cost, low touch, doesn't require therapist intervention or therapist contact, but it appears to be making a meaningful difference in the trajectory of their surgical recovery. And we're reporting primary analgesic benefits from it. And this is particularly important because orthopedic trauma surgery is a painful surgery where people will report moderate to severe pain months later. So we really need this portfolio of ways to treat pain at lowest risk so that we're not just giving people pharmacology and potentially increasing some of their risks. So we've been pretty excited about that. And what we've been doing, so that study that I just presented, published in Anesthesia and Analgesia summer of last year, 2022. So what we've been doing in the last year is creating a really enhanced version of empowered relief for surgery. So the data that I presented to you is kind of like a beta version where it was me in my office, creating a video against a green screen. But based on our really positive results, we decided to invest in this, developing an intervention that's both interactive, really a seamless journey for people to flow through the material, the didactic material, experiential exercises. They complete forms right there, surveys right on their screen, and they create their personalized plan all in this one-stop shop intervention that is delivered fully online. So we've been doing that for the past year, and I'm going to attempt to show you now a 3-minute video trailer that just illustrates for you what this is like for a person. So it will just sort of give you a little vignette of what the surgical intervention is like. So hopefully the audio and the video both play. It's 3 minutes, and then I will just wrap up and take questions.
I was describing
within the context of having medical conditions and ongoing beliefs and expectations. Your mindset impacts your health, called My Surgical Success. We found in a randomized controlled trial.
She's a co-chair of the American Academy of Pain Medicine.
So this is this constellation of.
Hello, and welcome to your Empowered Relief course. Empowered Relief is mind-body medicine for health and healing after surgery or injury. Empowered Relief has been studied in 2 surgical studies. People who received Empowered Relief reported less pain for up to 3 months after surgery. This is the purpose of Empowered Relief. Okay, let's start your journey to Empowered Relief. But do you know how deeply connected pain and stress are? Let's explore this connection through a story. As your brain registers pain, it triggers the response to pain is similar to a stress response. Being unable to escape your pain can be very distressing. Recovery mode requires that we need to learn new ways to calm the nervous system. This means you'll have greater comfort while your body recovers. We'll talk about how you can apply this information and learn new skills to recover more quickly from surgery or injury. You know that pain is stressful. Being unable to escape your pain can be very distressing. It's the first step to Empowered Relief. This program includes a special calming audio to binaural audio, has subtle tones. The sound waves work directly on your brain in a good way. Follow along with me and let's try it together. Rate how much stress you're feeling right now. Let's begin by taking a brief pain survey. Now, I'd like you to rate your level of tension that you feel. You're going to learn skills and tools to help keep your pain and distress low. The Empowered Relief program helps you develop supportive thought patterns so you feel better and have a smoother recovery. This is your central nervous. This is true. This is the formula. This is important. This is Empowered Relief.
Okay, so that gives you just kind of a nice flavor of what people are seeing, some of those medical animations, the didactics where I'm on the screen, people completing surveys, completing their personalized plan. So it's really interactive, fully online, and available on demand. So we're pretty excited about transitioning from in-person classes to expanding the portfolio and also offering classes online, as well as developing these on-demand and automated treatments so that we can really and truly meet patients where they are, regardless of their means or proximity. So a primary goal is to really dismantle pain care disparities that exist and really contribute to a lot of needless suffering, particularly of patients who have the least means. So just to summarize, and then I'll be delighted to take questions, broad integration of behavioral pain treatment is really possible. My line of work and that of my colleagues and team just stands as one illustration of the headway that we're making in this space. Our evidence shows that brief treatment can yield lasting reductions in pain and broad symptom management, both for chronic pain and also surgical recovery. And our philosophy is to offer these interventions to all patients so that everyone can benefit from optimized outcomes. And with that, I just want to really recognize and acknowledge my colleagues who really make all of this work possible and with whom I'm honored to be doing this work and also moving it forward into the world. So I think I'll pause there. I'm going to end the slideshow and I would love to take your questions.
That was truly an amazing tour of the incredible work you've done. I'm blown away and so excited about everything that you're doing. And I have questions, and as is always the case, but I always want to see who else has questions. So you can just go ahead and unmute yourself and ask questions. We have just so you know, we have a range of specialties on the at our grand rounds here today. I see faculty, residents, psychologists, psychology trainees, and as well as other clinicians represented. So you have a really nice representation here.
Terrific.
All right, I'll go ahead then. My question has to do with the utilizing the intervention in individuals with opioid use disorder or opioid misuse disorder. Can you describe a little bit more, any tailoring? Just tell us a little bit more about that work.
Yeah, absolutely. So we have various versions of empowered relief. You know, I described the surgical context, general chronic pain, and then one for opioid misuse or opioid use disorder. I just want to mention that, you know, at its core, it's really the same intervention and the same information, but that information is contextualized to the population. So, you know, you saw the surgery trailer is just referencing surgery. We don't assume that people have chronic pain in that context. For opioid misuse, of course, that patient population, they all have chronic pain. That's the purpose of the intervention. But we talk about the skills as helping people maybe reduce their need for medication or to help them stay on track with their medical plan. So we plant suggestions and statements throughout referencing how use of the skills can better manage pain and therefore need and use of medication. There's also, towards the end of the intervention in the summary, we give people sort of a rapid rescue tool to use where they're just able to very quickly go into some of the skills and information. And we're studying in this population where there's generally opioid craving, and the craving sort of precipitates, or it's the antecedent to some of the overuse of medication. We're going to be able to test whether or not providing people with this skill and also the basically the direction to use it as such will benefit people. We do see on balance, and maybe there's some really great substance use disorder clinicians and researchers here, or opioid use disorder, but of course we see that pain is one of the primary antecedents to first substance use, and it also contributes to the maintenance of substance use as well as relapse. So even though we're studying this in people with OUD and opioid misuse, we do think that long-term, we can study this intervention across different types of substance use disorder because pain is sort of universal and does contribute to poor abstinence rates and also to relapse rates.
I have a question. I think it went by quite quickly, but I think there, as you were listing what goes into the 1 session, 2 hour intervention, I think it said something like 3 core skills to learn.
Yes.
And I'd love to hear what those skills were.
Sure. Yeah, it's a great question. So recognizing that the skills are really anchored into a very strong rationale for, our understanding of pain and all of that. So that's just foundational. But then once we've established that, we move into the skills. So skill 1 is really using the breath to affect a parasympathetic response. Of course, we language it fairly simply, but we set the stage by discussing how pain elicits a stress response, how it elicits the sympathetic response, and how we can move people out of that in essentially calming the nervous system. So the breath is number 1. Number 2, simple cognitive restructuring. So people, as part of the intervention, they identify their challenging pain thoughts. They complete a survey before the class, which reveals to them what are their challenging pain thoughts. And then during the class, they're able to apply some of the information to develop some supportive statements that they can use when they're struggling or they find themselves in that circumstance. The third is a list of self-soothing actions. So again, when they identify themselves struggling cognitively and emotionally, the goal is to interrupt the unhelpful pattern that becomes automatic over time. So they can use the breath, they can use self-soothing actions, they can use some of these supportive thought tools. All of these are ways to intervene, to interrupt. And then they also receive the binaural audio, which is an additional supportive tool that they can use on a daily basis. So the binaural kind of folds into the first skill, which is being able to calm the nervous system through the breath.
We have a comment in the chat. I'll just from Dr. McBain, who works with on our trauma surgery service and does a lot of interventions.
Great.
Thank you for this is really exciting work. Thank you for an excellent presentation. In your studies, including traumatic injury populations, have you considered assessing for traumatic stress symptoms and how MSS may impact risk of development of post-injury PTSD?
Yeah, first of all, thank you, Dr. McBain. And it is a great question. We are hoping to be able to study that we have 2 grants going into the DoD, and very specifically focusing on one of them, very much focusing on trauma populations. So we don't have data on this yet. My hypothesis is that it will be beneficial, but to what extent and whether or not I'm right remains to be seen. But you're thinking along the same lines that we're thinking, and we hope to bring forward that evidence in the next couple of years. So fingers crossed we get the funding.
Have you looked at other premorbid predictors of response?
Yes, okay, so one of the biggest questions we get asked is, well, what if people have high levels of depressive symptoms or symptoms of anxiety? And we have not found that either of those are predictors of treatment response. So people who have high levels of depressive symptoms and anxiety are equally likely to respond to the intervention as people who don't. And in that study that the JAMA Network Open study, the criterion was chronic low back pain, but half of the sample had 2 or more chronic pain conditions. About a third of the sample had 3 or more chronic pain conditions. And we allowed people into the trial, even if they had moderate to severe depression. So we're kind of letting everyone in and just seeing how it shakes out. Our only exclusionary criteria in our studies is active suicidality. But beyond that, we're just really sort of broadly studying how the intervention operates.
Are there any other questions?
Any
I
other
have more, but torturing everyone. My question is, do you have this may be a, I don't know if you'll want to answer this or not, but so feel free to say, no, I don't want to answer that. You know, it kind of like a pet theory, like, why do you think,
Yeah.
you know, one session,
Yes.
what do you think is really going on? I think that's what I'm really asking.
You know, it's a really great question. And I'll tell you what I think. Even when people have access to something like a session CBT, they rarely get all of it. Most of the time people get half of it, or they get about 5 sessions of it. And so people are kind of getting maybe pieces of it. I have, I deliver pain CBT. I really, it's a good treatment. And I think that over 16 hours of content, for many people, we might be giving people too much to think about. So sometimes in an effort to be comprehensive, we can actually dilute people's focus on just, what's most critical. So I think that Empowered Relief kind of really brings it down to like these 3 steps, this actionable plan, and that's it. That's what you do. I think that registers really well for people versus taking a course. Of course, this is a generality. Some people need the course. I'm just saying, I think that this is a unique benefit. The other thing that's unique is the audio file that accompanies Empowered Relief is binaural, and that has shown to have primary effects for reducing anxiety, for reducing analgesic requirement when people are under surgery. There's also been some suggestion that it may benefit chronic pain. And of course, this strategy of binaural is used in EMDR treatment as well. And so I'm sure you may be familiar with that in regards to trauma treatment. So it is possible, Laura, that this particular tool is having, sort of evidencing some enhanced benefits. We haven't yet done the mechanistic examination of whether or not a person's level of engagement with the app is what predicts their treatment response, but that is exactly our next focus, is to determine to what extent does the binaural predict or mediate these changes, because CBT, they have all of this relaxation, but they don't have the binaural relaxation. So that's a hypothesis, but it's just a hypothesis right now.
I loved hearing you go through this incredible, I was not just an assortment of work, but kind of how your journey in developing this intervention, boiling down into these critical elements, thinking about this as a utilizing a brief intervention that now you can scale. I mean, the number of people who've now received this is incredible. How
Thank
you've done
you.
that. And so I think that shows a model. I just, I think that we probably have a lot of interest here, and people's wheels are spinning about thinking about that. And I hope, and we'll reach out, because I think we could think of some ways to potentially collaborate.
Oh, please do.
Okay.
And I'm happy to be a resource if people are really interested. I think that briefer interventions are the future for scaling access to psychology and behavioral interventions, across different disorders. So would love to brainstorm with anyone who has interest. And thank you so much, Laura, for the invitation. It was wonderful to share with you.
It was great. It was wonderful presentation. Okay. Thank you so much.
Thanks, everyone. Take care. Bye-bye.